Today, I'm going to be talking about some of the ethical issues that arise in reproductive genetic carrier screening, drawing on the stream of bioethics research that was conducted as part of the Mackenzie's mission pilot project. And I understand today's audience is quite diverse. There are people from all different sectors and from all different backgrounds. And so I'm not assuming too much. So I will be explaining a little bit about some of the central concepts like population health, public health ethics, what carrier screening is about, and I'll be explaining the Mackenzie's mission pilot as well. I'd also like to give an acknowledgement, sort of a blanket acknowledgement for my whole presentation to Professor Ainsley Newson at the University of Sydney. Ainsley was the bioethics lead for the research conducted as part of Mackenzie's mission. And so she and I worked very closely on all of this kind of work that I'm presenting today. Let me see if there we go. Okay. And thank you, Molly, for acknowledging country. I'd also like to acknowledge that I'm coming to you today from the ancestral lands of the Gadigal people of the Eora Nation and acknowledge them as the traditional custodians of this beautiful part of the world, which has never been ceded. So just to give a bit of structure to my talk, I'm going to speak first just a little bit in a general sense about some of the ethical issues that arise in genetics and genomics. Then I'll broaden that out and talk about population genomics. I'll explain what I mean by that and some of the ethical issues that arise when we scale up offers of genomic testing and screening across whole populations. And then I will be looking at a couple of the specific ethical issues that we identified as part of Mackenzie's mission. So just as an example, the concept of severity is one of the sort of the rich and complex concepts that I'll just be spending a bit of time explaining as an example. Okay, so first of all, just to talk a little bit generally about genetics and genomics to provide context and sort of orientation for what I'll be talking about today. We're obviously all familiar with genetic testing. It's not a new thing. We all know about things like the increase in BRCA testing, and I've got a few headlines and sort of images here that show some of the ways that genetic testing is sort of discussed in the public discourse, the kind of breadth of conditions and applications that genetic testing is purported to have, things like depression, autism, prenatal planning. This is genetic testing, carrier testing, that image there, I'll get to that one later. But this is just to show you how in the context, if we think about genetic testing, it has a lot of potential and a lot of power, but it comes with all this hype around it. So as we learn more and more about the genes and the genome and what they mean, what our genetic information might mean for how it contributes to health and other characteristics, there is all this hype and ethical questions arise when we think about how we ought to be using this technology. So as the technology advances, it becomes faster and cheaper to sequence a genome, but there's still a lot that we don't understand. So a really central ethical question that I'll come back to again and again is how should we use a particular technology? How should we use an application of genetics? And we can answer that question in relation to a particular individual system and also in the broader context of a healthcare system. So just to take a really simple ethical question, and I'm going to just give a little bit of orientation to people who might not have that much of an ethics background. When we think about ethical questions have a normative dimension. So they're asking about what we should do. They're not asking only about a fact that we can test out by examining the world. So statements that are normative are statements about what ought to be the case, what we should do. They can be statements about what we think is good or valuable. And there are a lot of these questions that arise in the application of genetics and genomics. So a really simple one is, how do we decide when a genetic test is appropriate? So that question, framed as a should question, would be, should we do this genetic test for this person at this time? And in order to answer any kind of ethical question, we need to have two types of information to inform that answer. Because it's a normative question, a question about what we should do, we always have to have some normative premises or normative claims that are informing our response to this question. So that those are things like values, value commitments, statements or claims about what we think is important. So things like, what are we aiming to do here? What is the purpose? Are we trying to cure someone's cancer? Are we trying to help someone do some family planning? Those kinds of questions. And we're thinking about who interests are we focusing on? Are we trying to achieve the best outcome for the patient in front of us? These are some of the sort of normative value-based questions that we can ask to help gather information that will help us answer the question of whether a genetic test is appropriate. We also need to have a lot of factual information, which can also be described as descriptive or empirical. So any kind of a situation that involves, to answer any kind of ethical question, we need both the normative element and also the factual element. So the facts of genetic testing, the facts relevant to this question about genetic testing would be things like, what kind of information might we get from that test? What kind of a test would be appropriate given the goal of the test? Is the result likely to improve the health of the patient? So things like that. And just when we are dealing with genetics and genomics, answering these factual kinds of questions about what kind of information we might get, whether that result is likely to improve health outcomes, then how we answer those questions is going to depend a lot on the nature of genetic information. So in the ethical literature, there is this whole debate about what's known as genomic exceptionalism. So that's the idea of whether we ought to treat genetic or genomic information as sort of a special and different category compared to other kinds of health information. Now, I'm not really persuaded that it's a whole different category of information, but it does have some particular features that we need to be aware of because they can increase the ethical complexity and raise some concerns about the way that we use genetic technologies. So the first one is that there's a lot of uncertainty, and I've got a reference, I've got several references at the end of my talk that I'm happy to share. One of them is a paper by Ainsley Newson with some colleagues who talked about this phrase known unknowns in the context of genetic information. And so this paper does a beautiful job of describing how there are many different layers of uncertainty that is inherent in genetic information. So they can be things like the probabilistic nature of genetic information. It can be complex in different kinds of dimensions. It can be ambiguous. In the sense that there can be unknown associations between the genotype and the phenotype and unknown penetrance. So there's the complexity of genetic information is very sort of multi-layered. Also, when we start looking at people's genomes, we can often see things which are not relevant to the reason why we went looking for information in the first place. So analysing someone's genetic information might give other information which we were not expecting. So what do we do with that? Another key feature of genetic information is that it doesn't belong to a single individual. So if we look at give a genetic test to a single person, then what we find from that test might also have implications for their family members. So communicating with patients about genetic testing, supporting them to make decisions about whether a genetic test is right for them can be very complex because they need to understand sort of what the value of that information might be for them, and also all this other complexity about its relevance to other people and so on. So this complexity is important because some people might have different kinds of preferences about what level of information they want. Some people are real information seekers. They want all the information they possibly can. Other people might have a preference, or that they might rather not know about all that complexity if they might find it burdensome or worrying or in some way. And if you're talking about information that is shared among family members, then it can be quite complex to navigate that if people have different preferences. We always have to come back to whether the information is useful or meaningful in relation to why we're looking for it in the first place. So here we have to pay attention to things like the uncertainty and ambiguity, because the information needs to be communicated to patients in a way that's meaningful to them, but also supports their capacity to make the best decisions. So if they can't understand how relevant the information is to the reason for testing in the first place, then that's something that we need to be wary of. Something to think about also is what comes after the testing. What kind of is the information going to be useful in informing the next step following the test? And then also the context of the decision making. What is the purpose of the test, and what is in the context of the patient's sort of broader situation, is it going to be relevant in that context? And then the other thing just to mention in the sort of general introductory sense is that as we move more from genetic testing to genomic testing, where we're looking in genetics, we would be looking at a single gene or quite a small panel of genes, looking at much larger panels or whole genomes or exomes. We start to get a much greater scale of information or volume of information. The scale increases enormously. And so what that means is that we get a lot more uncertain or ambiguous information, because there's a lot of the genome that we don't understand what it actually means. So we can get a lot more of these variants of uncertain significance. And then there's all these other layers of complexity, like the way that genes interact with the environment, how genes are expressed, the varying penetrance of different genes, and also what we understand about the genome is changing fast over time. So while a person's genetic information can be predictive of their future health, what that prediction actually is quite uncertain and can change over time, and it can change quite quickly. So that just sort of sets the background for all that complexity around genetic and genomic information. And I'll now talk a little bit about population genomics before moving on to specifically focusing on reproductive genetic carrier screening. So if we think about population genomics, it's important to think about the difference between clinical care, and public health. So we're all familiar with different kinds of public health programs, things like immunization is an obvious one, water fluoridation, different kinds of screening programs, public health screening programs, things like breast cancer, bowel cancer screening, newborn screening. These are public health interventions, are sort of interventions offered widely across a whole population, where everyone usually gets the same intervention. And the idea is that we're trying to improve the health of the population on an aggregate. So sort of we're trying to raise up the population health as a whole. By contrast, when you have the clinical context, you have a single, it doesn't have to be necessarily single, but you've got that, it sort of centers around that consultation between a clinician and their patient. And the focus is very much on trying to achieve the very best outcome for the patient in front of you. So the goal of improving the health of an individual, as opposed to trying to raise the health of a population or improve the health of a population on aggregate, is one of the main distinctions between clinical care and public health. So if we think about population genomics and what that might look like, in terms of the science and the technology is now advanced enough that the cost of screening has come down sufficiently that we can screen, it's become more cost effective to offer screening across whole populations. And also that we can look at hundreds, if not thousands of genes at the same time. So that means that population-wide screening for hundreds of conditions, or by looking at hundreds or thousands of genes, is now technically feasible. But if we think about the ethical questions that I talked about, when a genetic test might be appropriate, what is the purpose of the test? What is the information going to give us? Is it going to help improve the health of the patient? If we're thinking about offering genomics across a population, we have to always come back to what is the goal of screening. So as an example, in reproductive genetic carrier screening, which I'll describe in a bit more detail shortly, the primary goal there is to provide people with information that is going to be relevant for them in their reproductive decision-making. Another example of a pilot of a public health genomics program was DNA Screen. I think that was run out of Monash, actually. And that was a program that offered genomic screening or genetic screening to healthy young people, with a goal of providing information to enable early intervention or prevention for a specific range of cancer syndromes or inherited cancers and heart disease. So when a genetic test is offered, even if it's offered across a population at a wide scale in a screening kind of a context, we still have to think about what is the purpose of doing that genetic test? What is the goal? And then the information that we look for and the information that we provide back to participants should reflect those goals. And in the context of public health, also, we need to think about things like equity and access when we're looking at large-scale screening across populations. So just to give a little bit of an orientation, this is a slide that Ainsley and I both use. I think she wrote it originally. To make that distinction between the different ethical orientation or slightly different ethical orientation when we're looking at clinical care as opposed to public health ethics. So clinical ethics is very much focused on the delivery of healthcare to a particular patient. So it looks at that dyad, that image I had a couple of slides ago, where you've got the clinician and the patient, and the clinician's primary ethical obligations are to do the best they can to achieve the best outcome for the patient in front of them. So there's a lot of focus in clinical ethics on benefiting the patient, ensuring the patient's autonomy, things like confidentiality and so on. So it's very much oriented around that clinician-patient dyad. If we look at public health ethics still have an emphasis on, we've got liberty in there, but I mean, individual sort of freedom and autonomy is important in the context of public health, but we've also got this additional layer of the sort of collective communal values that we have to pay attention to. So we need to look at the distribution of the benefit of a public health intervention across a population. Things like equity and the social determinants of health are really important to pay attention to when we're delivering public health or designing public health interventions. And concepts like solidarity and relationality, reciprocity, all those kinds of concepts where we are sort of standing together with other people, we're all doing something in order to benefit everyone together, those kinds of values become more important in the public health context. And a particularly important one is trust. So trust is really important in the context of public health interventions. We all saw that, particularly in COVID, around immunisation. If you don't trust that an immunisation is going to be safe and effective, then you're not going to, then you're not actually going to go and get that immunisation. So any kind of a public health intervention depends fundamentally on trust. And something to think about, I think, that's interesting in the literature is this distinction between interpersonal trust, which is very relational. Interpersonal trust is the kind of trust that one person has in another person to do a particular thing, and it is based very much on the relationality, the relationship between those two people. And then, but if we're talking about government interventions, public health, healthcare systems, those kinds of things, we have to think about institutional trust as well. And that the focus, a lot of the focus in the literature is about what can make an institution trustworthy and what are the features of an institution that make it trustworthy. But that's just something to have in the back of your mind, that distinction between the relational kind of nature of interpersonal trust and then how that might translate into the institutional trust that is required to deliver a public health intervention effectively. In the context of genomics, where the trust is particularly important is that those people who are going to take up a public health kind of a screening offer of genomics, they have to have trust in the people who've designed the program. So they need to be confident that those who have designed the offering of genomic screening have paid a lot of attention to how the test is sort of designed, what the test is actually looking for, what kind of information they're going to get. So people need to trust that the people offering the genomic screening test understand that complexity and are going to give them information that is relevant and useful, because the stakes are very high. So the impact of a when you give someone a genomic screening test, or give them genetic information, the impact, as we saw, if you give them information which is not relevant to the goals of the test, or which might be relevant for family members, might be worrying for them, the stakes can be quite high. So that trust is really important. So if we think about how to implement public health genomics in an ethical way, we have to think about some of the equity kind of factors which are important in public health. So that's things like access to testing and screening in a country like Australia, where you live, whether you're close to a major city and a tertiary centre that has the capability of doing all those kinds of genomic tests is really important to pay attention to. I've talked about considering the value of the information if it's relevant to the goal of the test. We have this idea of utility. Is the information going to have clinical utility? Means, is it going to actually influence the clinical care of the person? But then there's also this idea of personal utility. And I think this is quite a useful one for reproductive kind of carrier screening, screening which is designed to inform reproductive decision making, because that's family planning is it's a personal decision. It can lead to medical interventions, but it is fundamentally a personal decision making process. And so you're providing information that has a great deal of personal utility in that kind of a screening test. It's also important to pay attention to what happens after screening in a population, in the context of sort of population genomics, because if some people can access follow-on interventions after a screening test, but other people, we have to think about costs, and things like geographic access to care and all those kinds of things. So access to follow-on interventions after a genomic screening test is a really important part of designing an ethical population genomics program. And also the impact on the healthcare system. If you're going to be giving everyone information or giving program participants information which is going to trigger follow-on further testing or follow-on interventions, then the healthcare system needs to be ready to absorb that. And there need to be pathways for people to access the care that they need or the support that they require after a screening test result. So I'll now move on to focusing more specifically on reproductive genetic carrier screening. And what I'll be talking about is drawn mostly on the research that Ainsley and I conducted along with many other collaborators in the Mackenzie's Mission pilot program. I've referenced the website there. The website is still up and it has a lot of information about the way the program was offered, what conditions were screened for, and all different aspects of the program and its governance and everything. So Mackenzie's Mission was a pilot program. It was named after a baby called Mackenzie Casella, who tragically passed away from a condition called spinal muscular atrophy type 1 when she was 7 months old. And Mackenzie's parents, along with other people with an interest in this area, clinicians and other advocates, they successfully lobbied the government to fund this pilot program to look at how to deliver carrier screening, because Mackenzie's parents were really shocked that they had never heard of this genetic condition. It was not in neither of their families had ever had a person who had this condition. They didn't know that they were at risk for it, but they also were unaware that there was a test that they could check if they were likely to have a child with a genetic condition. So carrier screening looks for, I'm used to speaking to quite genetics audiences, so just in case there are people from a not so familiar with genetics, carrier screening looks at people. It tests 2 members of a reproductive couple to determine to look for recessive or X-linked conditions. So that those are genes that they might carry that don't affect their own health and that they've been passed down to them from other members of their family who also were not affected by that condition. But if you have a child with somebody who carries the same recessive condition as you do, then you have a 25% chance of having a child with that condition. So that was the case for Mackenzie's parents. And it's thought to be the case for roughly between 1% and 2% of reproductive couples in Australia, that they carry the same recessive gene as their partner. So Mackenzie's Mission offered this kind of screening to about 10,000 couples in Australia between the years 2020 and 2022. And so a lot of data was collected as part of this program, all the clinical data, obviously, the outcomes, but also there was a very strong program of psychosocial research that looked at people's experiences and the way that they made their decisions about this kind of testing, both whether to test and also what to do after a test. And there was an ethics analysis that went alongside it and integrated with many aspects of the program, and also a health economics stream. So, and there's loads of data, and we're still working through analysing a lot of the outcomes from Mackenzie's mission. If we think about this kind of offer of screening, it looks a lot like a clinical test, because it was offered, Mackenzie's mission offered screening via healthcare professionals like general practitioners, obstetricians and midwives, and fertility clinics. So in some ways it looks like an offer of a clinical test, but it really has a lot of features in common with a public health screening program. So there are many ways in which we should be thinking about it as a public health program. So in a program like Mackenzie's mission, everyone gets the same test, and there's not that opportunity to tailor it to someone's family history. So everyone is, they look at the same genes in all participants in a program like this. Because it's publicly funded, or it's offered in this kind of routine way, it's not offered to you because you have a particular characteristic or you've got a certain kind of a background. Because it's offered to everybody in this blanket kind of way, and it's publicly funded, that sort of lends weight to the legitimacy of the program, and it kind of can lead to this, what we sort of think of as routinization or responsibilization, where it sort of starts to be seen as the right thing to do if your doctor offers it to you. But it's also really important, for reasons that I'll explain shortly, to make sure that people feel that they have the freedom to choose whether or not participating in a screening test like this is right for them. And also because of it being such a large-scale program, it's not tailored to every single participant. Everyone receives the same kind of the same information to support them to decide whether they want to participate. So for Mackenzie's mission, they developed this really cool decision aid, and there is a paper about that. The decision aid was a sort of an online tool that took people through a decision-making process to help them really reflect on what kind of information they might get and think about their own sort of preferences and values with respect to all these sort of reproductive decisions and choices that they might need to make to help them decide if it was right for them. And then the other sort of standardization, or sort of the aspect of scaling up to a public health kind of a screening program, is that the reporting pathways had to be the same for everybody. So a lot of it was, or a big part of Mackenzie's mission was finding out how to report results in an appropriate way that could be done in this kind of standardized way. So treating it as a public health screening program. So some of the ethical issues that came up was, first of all, this is the obvious one that often gets raised, is whether a program like reproductive genetic carrier screening is like eugenics. Obviously, we've all heard of those highly problematically, deeply unethical eugenics programs of the sort of mid-20th century, early mid-20th century. And it does have some aspects in common with it, because a carrier screening program could influence which future people will be born. And there is a sense in which it values certain characteristics of people, which is obviously it's trying to it's enabling people to try and avoid having a child with a very severe genetic condition. I'll talk about the eugenics issue in a little bit more detail on the next slide. An important thing to think about in population genomics is whether everyone will benefit from it in the same way. So in a country like Australia is quite diverse in terms of our population, and there are some population groups that are quite underrepresented in genomic data sets, and so they might have a higher rate of variance of uncertain significance. So that's one thing to think about. And then there's also the other things like that's the uncertainty and ambiguity. Some people might get more ambiguous results, or the results might just not be relevant for them. Have to think about whether everyone wants this kind of intervention, and health literacy with something so complex as genetic carrier status is something to think about as well. And then we have to pay attention always to considerations of equity in the context of a public health offer. So equity of access. In Mackenzie's mission, a lot of effort was made to reach people across Australia, including in more remote and regional areas, and a reasonably good job was done of that. I think really there's a very good spread. If you there is a map of all the people who took up the offer in Mackenzie's mission. But then also in terms of equity, thinking about the cost of follow-up testing. If someone receives a result that they are at an increased chance of having children with a genetic condition, what kind of options are available to them? Are they affordable? Are they able to access them near where they live? All those kinds of things. And then we also need to think about sort of the broader healthcare system and the use of health resources in population health. I'll just talk briefly about a few more about the eugenics issue and a couple of other ethical considerations in carrier screening. This is an example. Obviously, this is the more extreme kind of example of a headline, but there was a little bit of this chatter about this sort of critique of Mackenzie's mission early on. It did quickly fade out because, as I said, there were some similarities, but really importantly, there are some very ethically significant differences between a program like Mackenzie's mission and the very problematic eugenics programs of the past. So to my mind, there are two, and I mean, this is a position that we've written a paper about, so I have a reference to that one also, but the two main ethically salient differences between sort of a program like Mackenzie's mission is, first of all, that it is entirely optional and not coercive at all. So everyone has, there's no, so this is about the methods by which the program is implemented. So it is about providing information to support reproductive choices. It's not about trying to coerce people to make certain decisions based on their own genetic composition. And also there's a very explicit rejection of the idea that some people are more valuable than others or more desirable than others. So that in a population genomics program like Mackenzie's mission, and this was, there has to be this very explicit rejection of a preference for certain types of people. And so that means that it's broad and inclusive, and it's very strongly justified by trying to avoid the suffering associated with a very severe genetic condition. So the way that we responded to the eugenics critique is obviously about emphasising participants' freedom of choice. So that's both their freedom about whether they want to participate in screening. It was perfectly acceptable for people to say, to look at the decision, look through the decision aid and say, no, thanks, that's not for me. And the other thing is what to do with their result. If they were found to be at increased chance of having a child with a genetic condition, then what they do with that information is completely up to them. So there were efforts made to avoid suggesting that the right thing to do would then be to take steps to avoid having a child with that condition. It was up to the family to make that decision for themselves. And this is really about the way that we reinforce that, is that the primary goal of an intervention like genetic carrier screening is about supporting reproductive autonomy. So it's about providing information that is relevant to people in their reproductive decision-making and providing support for participants to decide whether it's right for them and what they do with that information. Another important part of responding to this critique is that recognition of the role that social norms can play. And I've got this diagram that I like to use because we have there on the left, we've got the choices that individuals and families make about their reproductive their own reproductive decision making, but those decisions are influenced by social norms and the sort of the context of the society and the community in which they live in. And then so by social norms, I mean things like ideas about what a desirable family might look like, what sort of fundamentally what constitutes a good human life, which is really what all ethical decisions really come back to, is that idea of, we have an idea of what a good, flourishing, human life looks like, and we want to achieve that for ourselves, for our family, and so on. So our idea of what that looks like is going to inform the way that we make our individual decisions. And we also need to recognize when we offer a program and design a program like reproductive genetic carrier screening, that the aggregation of many individual reproductive decisions can have the capacity over time to shift these social norms. And so that's something that we need to pay attention to. So another, moving on from the eugenics question, another issue which is quite ethically complex in carrier screening is how to report results and what results to report to participants. So one thing that you can do is test every individual and report their individual carrier status. But in a large-scale program like Mackenzie's mission, which offered screening to and did perform screening on nearly 10,000 couples, the majority of people, sorry, I don't have the percentage, but it's a high percentage of individuals, all of us are carriers for some condition or another. And so to report that result to every individual participant, explaining what that means for them, that it probably doesn't have implications for their own health, and then what they do with that information is burdensome from a resource perspective, but also really importantly, it's not justified in relation to the goals of the program. The goals of the program are to provide people with information to support their family planning, reproductive decision making. So for this reason, in Mackenzie's mission, only joint carrier status, so couple-based results were reported. And this is a well-defended approach, which has been used in other countries around the world. And there's empirical research that suggests participants find it acceptable, and it's very robustly justified both by the goals of the program, as I've talked about, and also on pragmatic grounds, because it's just not feasible to provide, ideally genetic counselling for everyone who has a carrier, who is a carrier for something. That's one issue. Another question is whether carrier screening could be an opportunity to give people more genetic information about themselves, beyond carrier status. And we know that, so this is the question of whether because we're doing a genetic test on people who are thinking about planning a family, does this present an opportunity to look for other actionable secondary findings, like cancer predisposition, for example? And so this is something that, and we do know that people tend to say yes if you offer them more information on the whole. But again, this kind of question, we think, comes back to like it's very challenging to do at a large scale. Some of the findings might not be clinically useful, because it might be, if we think about personal utility, explaining that to participants at a large scale, if you're looking at thousands of people, making sense of that, whether they then need to have follow-on screening, follow-on interventions, screening for their family members. It becomes a very resource-intensive exercise, and also goes beyond the goals of the program. And there are equity issues in reporting more results than that as well, because then the availability of follow-on interventions is, this healthcare system is limited, and different people might have different levels of access to either follow-on testing or other interventions. So I think it's, limiting the results reporting to the goals of screening is important when we're thinking of offering it across populations to thousands of people. And finally, the last sort of ethical issue that I'll talk about is about choosing what genes to screen for in reproductive genetic carrier screening. Now, a lot of effort was put into designing the gene list for Mackenzie's mission. This is not the gene selection paper. This is another paper that we've written about some of the complexity. I've also got a reference to the paper which described the gene selection process. A lot of these points here I have mentioned already, but I think what I really want to draw attention to here is the trust that program participants have in the people who design a program. So they have trust that when putting together the gene list for a program like Mackenzie's mission, people knew what they knew about the complexity of the information that people might get. They knew about the goal of the program. They understood the conditions and the relevance of the information, and that they would only give information that is actually relevant for the purpose of the program, which is to inform reproductive choices. And it's also important to keep in mind that these, I talk about the sort of implications for including a condition, are if a condition is included in a public offer of screening, that suggests to the population that it is a condition that is worth avoiding. So that's important to keep in mind. And limiting screening to conditions which are thought of as severe is really common. I think in pretty much every genetic screening program, among the criteria is usually you find this concept of severity or seriousness. But this is a paper that we've written about this concept because it's very complex to draw that line. There's obviously, if you think of all the genetic conditions you could possibly screen for, there's a lot of agreement about the milder conditions. There's a lot of agreement about the very severe conditions, but there's this very wide grey area in the middle. And people's perceptions of how severe a genetic condition is will vary according to lots of different things, but particularly their personal experience, whether they have lived with a family member who has a genetic condition or another disability. It'll also depend on the context of the community and the healthcare setting where they live, what kind of supports are available, how severe they think a condition might be. And also if they're a clinician who has experience with maybe the more extreme presentations of a condition, they might have an elevated sense of how severe that condition is. So there's a lot of different factors which can influence how severe someone perceives a condition to be. And so what we thought in this paper, what we've concluded is that it's really tricky because you need this in designing a carrier screening program, you need a very generalized approach. So you need to have a sort of an aggregated general sense of how severe a condition is. But then when a couple receives a result that they have an increased chance of having a child with a particular condition, then they require a much richer picture of what that condition might look like. So at that individual and family decision-making level, they really need, people need to have be supported to think through the implications of what that condition might look like in their future child. So sort of make that distinction between the severity of a condition in aggregate versus the severity of an instance of a genetic condition in a particular person, which requires a much more nuanced kind of a picture of what the condition might be like. So that is a real challenge for designing carrier screening programs, is deciding what to include on the screening list. And so that brings me to the end of what I've prepared, and I do have some references that I'm happy to share, but in the meanwhile, I can stop sharing my screen if there are any questions.